Good morning, good afternoon, and good evening to anyone joining us today. My name is Joan Stein, and I'm a member of the IDDSI board. On behalf of the International Dysphagia Diet Standardization Initiative, I'd like to welcome you all to our webinar entitled Infants and Young Children, Dilemmas and Decisions with Liquids. We would like to thank our generous sponsors who allow the work of IDDSI to continue and who support implementation around the world and are part of the reason why we can bring you these types of webinars. I'm going to do some quick housekeeping before we begin. So this webinar is being recorded and will be available on our website probably sometime next week. So if you have to leave early or your colleagues didn't get a chance to listen, then you can certainly pass that along. All participants who join us today are in listen-only mode. That means the panelists won't hear or see you, and your microphone and video will remain off. If you have any questions, you can submit them through the presentation. To do so, use the Q&A button on the middle of your menu bar. Our speaker today will address the questions at the end of the presentation, and we'll have probably about 15 minutes or so for the question and answer period. IDDSI does not currently offer continuing education units, but in the upcoming days, a certificate of attendance will be emailed to anyone attending the session through a computer. If you're joining us through a phone line, please email us at meetings@iddsi.org to let us know who you are, and then we can email you this certificate. I think that's about it for the housekeeping. So I can't tell you how excited and thrilled I am to have the honor of introducing our speaker today, Dr. Joan Arvedson. She is just the most amazing lady, and definitely someone in my career as a pediatric therapist who I followed a lot. So Dr. Arvedson is the program coordinator, feeding and swallowing services at Children's Hospital of Wisconsin in Milwaukee. As well, she's an educator up in the Department of Pediatrics. I think many of you will know her books. She has 3 books in publication and many, many, many articles. She's an amazing researcher, internationally recognized expert in pediatric dysphagia, and was awarded the honors of ASHA in 2016 and is an ASHA fellow. So I'm so thrilled to be able to bring this forward. And so Joan, I'm going to pass it over to you right now. Please go ahead.
Thank you very much, Jan. It is a privilege for me to share in this webinar, and I always try to do too much, especially in a short time frame. You have access to my PowerPoint slides. I believe those have been sent to you, and whether you download them or you just use them, but know that as we may shortcut a few slides, you have access to all of the PowerPoint slides. So without any further comments, let's just move on. This is one of my favorite sayings. It comes from Danton's Memorial in Paris. He was a primary figure in the French Revolution, and it says, as you can see, education is the greatest need of the people, but first they must be fed. And that's a reminder to most of us like to have something to eat and drink before we get into any kind of an educational session. But even more so, every one of the infants and children whom we see, we must make sure that we do nothing to jeopardize their nutrition and their hydration, and safely, because they must be fed. This is a schema that I've used. Some of you, I'm sure, have seen it with me. And it's a triangle here, but you notice the links are somewhat circular and they all interrelate. So airway, we must have a stable airway in order to feed orally. The gastrointestinal tract has great implications on whether our children have any interest in eating, and if there are problems, pain, discomfort, vomiting, those are all negative factors in oral feeding. And then here I put feeding and swallowing. I suggest that all of our children have feeding disorders, feeding problems, because that's the broader term. And some of the children that we see have dysphagia or swallowing problems. And it is important to think about those distinctions. And what is at the center of all of this? It's always the brain. Everything about what we do is neurologically based. So I emphasize the primary needs for all humans, probably all living beings, respiration, airway, and nutrition, hydration. And I always remind people that whenever I use the term nutrition, I want you to be thinking hydration, because the adequacy of fluids is so critical at every age and stage. And feeding should be pleasurable. This is a reminder to say it should taste good, feel good, smell good, and not be stressful for the child or for the parents or any other feeder. So we will consider for today terminology, a little bit about evaluation, some decision-making principles, strategies and rationale, but this is not a course. I can't do that in 45 minutes to really talk about intensive interventions or extensive. What do we have for evidence-based outcomes? And then I think this has to be a fine balance between art and science. We should always be thinking scientific basis, but there also is a lot of art in terms of our interactions and are constantly looking for new information and new ways to do things. So what do we have for some of our descriptive terms for liquids? I think of very thin liquid as water, breast milk, and juice. They are not the same as milk, infant formulas. I think of those as thin liquid. Now, you also know that in many instances, we just talk about thin liquids and people don't make that gradation. So it tells us right now that we don't all use the same terms in the same way. I don't know about those pre-thickened formulas. They seem a little thicker to me even before they get into the infant. And then we use the term nectar. Well, what does that mean? There are probably a whole range of things that are nectar. And honey, people talk about a honey thickened liquid. I ask all of you, is that really a liquid? I find that hard to believe. And then some people even talk about pudding. That's not a liquid as I understand it. Now we will look at the way IDDSI has been able to become more descriptive with some numbers put to things that help us. It does not help us in our decision making specifically. And that's what we're talking about today, decision making. So one person's description might differ from another person. And the commercial products may vary even if they have the same label. So if one is thinking about doing anything that changes the texture of a given liquid, it's better to have a specific recipe. So I would say to somebody, add 10 milliliters of rice cereal or oatmeal cereal or a commercial thickener in 30 ml, whatever that liquid is. Now I'm just making up the numbers, but I think you get the picture. And then if somebody is on a thickened liquid, and we'll talk about this further, if it's a timing problem, you want to help children get to thin liquid. Well, how are you going to do it? Well, now we can measure better, but it might be that you reduce the amount of the thickener by a very small amount in the same volume of the liquid that you've used, but you have to be very specific, because if a parent is doing 8 ml of a cereal and putting that same thing into 30 ml milk versus 30 ml juice or water, it's not going to be the same. And we'd like to just monitor the child's timing and coordination. You don't want to take them back to a radiology study every time you're making a little change. Here's the schema from the IDDSI. You can get it on the website. I'm not going to talk through this one. So when do you consider thickened liquids? One of the possibilities is when the risks for aspiration with thin liquids, even after therapeutic changes, that could be positioning. For an infant, it could be the nipple flow with a straw or a cup. For other children, or when the signs and symptoms, and remember there's a difference between signs and symptoms. Signs are what we can observe, symptoms are what people report. Well, most of the babies and children I see can't report their symptoms, so what do? We infer the symptoms from some of the signs. So when those pose greater threats than the negative effects of the thickeners. Nothing is perfect. There are always pluses and minuses, pros and cons with every decision we make. Now, I want to speak briefly about breast and bottle feeding infants. Even if some of you are seeing older children, it's important to understand where these babies and children have come from, whether they're preterm, whether they have other etiologies. So we're always looking at things developmentally. We know that breast milk is the best nutritional choice for infants. American Academy of Pediatrics, American Medical Association, World Health Organization, and these are some of the benefits of breastfeeding. So you just read through that quickly, and I don't have to speak to all of them. It is interesting that because things can differ with the mom's diet, those infants are getting different tastes compared to an infant who is on a fixed formula. So there's some evidence that there may be better acceptance of foods in that culture later. This is one of my favorite photos, in utero, probably at about 24 weeks gestation. Where are the hands? They are at the mouth. Thumb, fingers. Infants are doing that non-nutritive, rhythmic kind of sucking in utero. And that's what we want to promote once they are in our world. Now, I'm going to give you just a little bit of information here with some recommended standards, competencies, and best practices for infants in the neonatal intensive care. Systems thinking, and these are the areas: reduce pain and stress, position and touch, sleep and arousal, skin-to-skin contact, management of feeding and eating. And this has come out of a consensus panel through the Gravens, international and multidisciplinary. We had meetings beginning about 6 years ago. Subgroups were formed. We did extensive literature review, looked and determined the levels of evidence so that we could develop feeding standards and competencies in all of these areas. There is a summary manuscript that was published in 2020. Here is the website. I urge all of you to go to that website, and you will find lots of references, the access to the executive summary, and with a lot of the guidelines that we've come up with. So what we're really urging people to do is to look at those, and those of you who are in NICUs, share them with your team, and may help you in getting an overall environmental change and aid in making your whole infant and family-centered care even better than what it is now. One of my basic philosophies of life is what we're doing today is okay, and it's probably pretty good, but we can make it even better. So it's not that we're trying to change something from bad to good or any dealing with right and wrong, but always making things better. Look, in the infant, here's a mom. You can do loving and looking, but not even touching at this point with this baby. This photo was sent to me from a colleague in Sri Lanka. And I share it with you with a sense of how can we be creative as we are in different kinds of environments and have different access to certain kinds of equipment. They don't have pacifiers like we think of them in the US or Canada, or in, I'm not even sure where all of you are from. But she rolled gauze. Here's the mom with the therapist here, and she's going to dip it in the express breast milk to give the baby a taste and help that baby get non-nutritive sucking going. And then she can throw the gauze away and start again with essentially sterile gauze. So art and science, creative ways of helping to make things function. So here's one study, there are several, about non-nutritive sucking. So you can read what the study itself showed. And I like to think of this as non-nutritive sucking is a necessary but not sufficient skill to transfer automatically to nipple feeding. Because with non-nutritive sucking, that infant does not have to coordinate, suck, swallow, and breathe because they don't have to do that frequent swallowing. You know, the rate of non-nutritive sucking is about 2 sucks per second, and nutritive sucking at breast or bottle is about 1 suck per second. So you can check this review and follow more of what that we don't have time to talk about here. We have really gone to what people call cue-based or infant-driven feeding. So rather than every 3 hours, a certain volume expected for infants, we want to build on the infant's cues. So that requires feeders, nurses, therapists, parents, to interpret the infant's cues. And a multidisciplinary team with parents being primary really results in improved feeding success and parent skill. So this comes from this particular article. And if some of you want those articles, and it's not easy to find it just by the way I have the reference, you let me know and I will help you get it. So there's limited evidence from a number of randomized controlled trials, although they all have method weaknesses, they're small sample sizes. But with this ad lib or infant-driven earlier total oral feeding, and in some studies, they get discharged earlier. But in some other studies, they may get to total oral feeding sooner, but they don't necessarily get discharged sooner. We have to keep reminding physicians particularly that it's not about volume, it's not about trying to push that child, but to facilitate and get the best feeding possible in the overall picture. What we don't have are reports of parent, primary caregiver, or staff views in this Cochrane review. Here's a little infant who has inspiratory stridor, which is very common with laryngomalacia. I'm going to show you a little bit of this clip to see how nicely coordinated he is. He's being fed by a parent, looks like side lying. Side lying can be useful for some, but it's not 100%. But he's feeding fine, even though he has the inspiratory stridor. I'm not going to take time to show any more. I'm hopeful that you could hear that inspiratory stridor. But he's looking coordinated. His pulmonary status is good, and he's going to get better over time. So just because there's pretty frequent inspiratory stridor, it doesn't necessarily mean that that infant cannot feed with a regular formula or even be able to do breastfeeding. Wouldn't necessarily take every one of these infants to radiology for a swallow study. A lot of observation. All right, now breastfeeding is encouraged when the mother is present. Typically, infants are weighed before and after the feeding. If the weight change is less than the volume needed, they may finish with a gavage feed, tube feeding. They're usually determined to be on full oral feeding. That's what PO is, when all the feeding volumes are taken orally in a 24-hour period with no need for supplemental gavage feeding. Here's a photo of the mom getting the breastfeeding position and a therapist helps to get the best position. Infant needs to be in midline posture. They're basically tummy to tummy. You've got to make sure that the lips are flared out, both upper and lower, and that holds for bottle feeding as well as for breastfeeding. And notice it looks like the infant's hand is upright on the breast. This is probably the mom's hand. So just that photo. In our place, we do many of these assessments with a lactation consultant and a speech language pathologist. Some of you may have combined skills, and that's great too. The recommendations from the American Academy of Pediatrics: exclusive breastfeeding for 4 to 6 months, or if babies are bottle feeding, they're with their liquids. No introduction of solids until at a later time, and there's no up preparation. So we need support, and that has international implications as well. The benefits, oops, I really went after that fast. But even after 75 years of study, this was from 2007, but even to 2020, we don't have adequate understanding of the relationship of breastfeeding to neurodevelopment. So we always have more questions, always have research possibilities. Preparation for breastfeeding is the skin-to-skin contact, and that's the term that is used more commonly now than kangaroo care, which was the most common term 5-10 years ago. But I urge you to think skin-to-skin contact, and that can be important for fathers to do with their infants as well. Clearly, they're not going to feed them, but the skin-to-skin. So mother's milk supply, they can get taste, their readiness cues are similar for bottle nipple feeding, and I've already mentioned the team. So I want you to be aware of the World Health Organization, UNICEF, 10-step criteria for baby-friendly hospitals, and that's international. So all clinicians involved in guiding mothers and babies for breastfeeding are urged to go to the website for the World Health Organization, and you can see how these 10 steps provide a systematic process. It is interesting to me that number 9 says no pacifiers or artificial teats. Our clinical experience, and I have to emphasize clinical experience because I don't have a research data-based reference to share with you at this point. Many infants with the appropriate pacifier experience will attain both breast and bottle feeding sooner and better than simple oral motor intervention. It is very important. And when you think about it, if an infant can't coordinate the non-nutritive sucking pattern, how could we ever expect them to then coordinate suck and swallow and breathe that's needed for both breast and bottle feeding? Now here's an infant who was not taking oral feeds. He had a gastrostomy tube. No child should be totally NPO. They have their saliva, they need to be swallowing their saliva. So how can we facilitate taste in this child who is not yet 6 months old, so he isn't really ready for spoon feeding? But presentation of the expressed breast milk, or if it's formula fed, on a small flat spoon, let's see if he just kind of suckles it. Just watch a little bit of what I did. Doesn't mean it's the only way, but I want to give you an example.
So first of all, we're just gonna touch this with nothing on it. Just want to know that he would sort of suckle at this, which is what he's doing. And now we're going to put a couple of drops on the spoon, and here it comes. Yeah, look at that. Here it comes on your tongue. And so I'm just tipping it off, and I'm actually doing almost a little pressure down right at the middle of his tongue, because that's where we would really do spoon feeding. That's about where the nipple would release this. Here it comes on your tongue. And see, sort of. And the reason I'm doing this is that he's used to the taste and he's used to the consistency. So the only thing we're doing differently is how it's getting into his mouth. And clearly the amount, because he isn't going to really suckle it off. There you go. And
that kind of taste experience can also carry over, we think, to more frequent swallowing of saliva, because that's a little bit different process than with a taste or some kind of liquid. So just a little example for you.
So first of all, we're just gonna.
Moving on. When there are concerns for pulmonary problems, an instrumental swallow evaluation has to at least be considered. We would prefer that all infants and children can drink thin liquids safely and efficiently, with no negative impact on their pulmonary system or their GI tract, with adequate nutrition, and it's often a very important element of their nutrition as well. Question of aspiration. It is impossible to determine whether a child or anybody aspirates just by observation of drinking and eating. And sometimes we'll have a parent say, I know he's okay when he aspirates because he coughs. Well, a cough isn't necessarily going to clear anything out of the airway. even if he would aspirate. Or you get the other statement, especially when there's a neurologic etiology of, well, he doesn't cough, so I know he's not aspirating. Well, we simply cannot know that for sure. So, this is the highest risk area that any of us practice in, those of us who are therapists, whatever our therapy specialty is. We can harm children. So it's extraordinarily important that we don't practice in isolation. But moving on here, what is the state of the art in science for evaluating these infants and children? Clinical feeding evaluation is critical so that you get an observation. No one should go to an instrumental assessment as the first trial of any kind of oral feeding, except in rare exceptions. The flexible endoscopic examination of swallowing is often very helpful when upper airway and swallowing concerns are noted. Like that little guy with the inspiratory stridor, the FEES exam may be very useful for that child. The video fluoroscopic swallow study is typically done as a standalone examination. For selected patients, we combine it with esophageal manometry. I'm not going into that today. Ultrasound is another instrumental possibility. It's not used routinely in our medical facilities, at least that I know of. Sucking patterns can be observed well. Extensive training is needed. And if we could use that more accurately and more specifically, wouldn't that be great? We wouldn't have to take children to radiology or to have a flexible scope put through their nose and into their throat. All right, what are some of the challenges? Well, most of the challenges, the infants and children that I see at least, do not have a normal neurodevelopmental status, probably from the beginning. They make changes with developmental gains, even children with complex etiologies. Most are expected to make gains, but there's a huge variability within and among children. I often tell parents the only thing you can predict about your baby or your child is that she's unpredictable. They tend to agree with me. Our interventions overall lack sufficient evidence and outcomes data. Now, I do want to speak briefly about instrumental challenges particularly. The video swallow study, modified barium swallow study, was what Jerry Logeman called it when she first described it. Most used it through the US, Canada, Central South America, I think Europe, Asia, and other countries. There are some risks with radiation exposure. The thyroid gland has to be in the view. Our institutional review board nearly always asks, if we're going to do a research study, what's the risk for cancer by age 40? Well, that's a little difficult to answer, isn't it? The orbits of the eye are very sensitive to radiation, and that's difficult to keep out of the view, especially if you have a child who's moving. The online decision-making is critical. So when do we need to do this? We need to describe pharyngeal and upper esophageal function. We can only infer by observation. I've already said that. But remember, it's a limited sample in an atypical situation. The study does not have a primary purpose to rule out aspiration. And we all have to keep reminding people about that. Its purpose is to define physiologic function. And I'm not sure I put this statement on a slide, so I'm going to say it right now. It is not a pass-fail test. And I will still have parents come in and say, she passed her video swallow study. We have to help people remind it's not pass or fail. It's a descriptive study for some very specific purposes. It's vital that we use continuous fluoroscopy. At least at this point in time, we know that we would miss too much about swallowing if we were not using 30 frames per second or continuous. So check with your radiologist, those of you who do these studies. There is at least one study in the literature that shows that 30% liquid swallows with laryngeal penetration were missed if the rate was only 15 frames per second. And some want to do it even less. This is a very important concept, ALARA, as low as reasonably achievable, which is a principle for all radiology examinations. And we need to keep that in mind too. So the coning is important as well. Let me show you just a brief portion of an infant, 2-month-old infant who was coughing during feedings, had a number of etiologies, and there was a question about possible aspiration. There was that kind of question. So this is just a study. The permission has been given from all the parents, and I want you just to watch how really well this infant is doing.
Recording.
So it's Arvedson, which I figured gives us a better contrast. She's looking good. You keep looking at her. I am.
She looked remarkably good. 1 suck, 1 swallow, and that was a pattern that continued for a sequence of about 30-second swallows. And then we turned the fluoroscopy unit off, let her keep sucking and swallowing without any interruption. And then we turned the fluoro back on after probably less than 2 minutes, so it wasn't a total feeding. And then the radiologist and I both looked very carefully to see whether there was any contrast in the trachea. There was not. We observed a few more swallows. And then I also watched her do more feeding after this study. So it's a brief sample in time, but it gives us some important information.
Recording.
Here we have a 4-year-old who has a left vocal fold immobility and a necrotic epiglottis. And that occurred because he had a subglottic stenosis and a pseudomonas tracheitis it was the tracheitis that caused the necrotic epiglottis. He wanted to take thin liquids. He was doing some drinking with thin liquids. We had done a fee study with him a few weeks before we did this study. And I'm starting with thin liquid on a spoon. So it's a very controlled amount.
Yeah, thin liquid by spoon. This is Arvedson, just swallow it. That was pretty little. I'm going to do one more and then we'll give it a cup. That's a boy. Okay, nice quick swallow cup. This is our thin variant by over cup.
So now he's going to cup drinking. He looked okay with a very small, like a single sip.
Just swallow it right down whenever you're ready. Good. Again. Oh, nice. Very good. Couple more. Oh, wow.
Then he gets a little trace aspiration with the consecutive swallows. So what might be the intervention or the recommendations? He needs practice with thin liquids, practice with water, single sips, and keep his thickened liquid for his consecutive swallows for now, gradually work with the thinning. And if his pulmonary status stays clear, he may be able to go on to fair amount of thin liquid. So it's very important that we get enough information during the radiology study that really helps us with our decision making, not by the swallow study alone, but the swallow study combined with clinical observation, possibly fees, possibly pulmonary status, and a whole range of information. So we have to think about the total child while each one of us practices in our school practice. And I love cartoons. So this one just reminds us, and I think it's a good part of the reason how speech pathologists got into this field. These children, they fuss, and here comes mom, some yummy strained broccoli. They don't care whether we think something's yummy at all. And here he says, I gotta learn to talk. So we often, probably more often than not, are inferring by facial cues, gestures, etc. But gotta learn to talk. And we always have to be thinking about the communication. So here's where I consider the major unanswered question. How much aspiration of what can a given system tolerate before chronic lung disease becomes a problem? And that I mean unanswered for every one of us involved. Researchers, clinicians, physicians, it doesn't matter. This little guy's doing straw drinking at home.
If you keep on eating, we'll keep it coming. All you can eat riblets and tenders at Applebee's. Now that's eating good in the neighborhood.
Mother Nature. Nothing smells greater than the great outdoors. Especially
Put your hand out of the
when
way, buddy.
you're
So as the session went on, they sent me this from home. he began to do a little bit more with the straw drinking. And, you know, straw drinking is very appropriate as we even get into adulthood. Now I'm going to show you just this clip of a child with craniofacial anomalies, lots of other problems, at risk for aspiration with a feeding tube. But watch the cup drinking with his mother as a first practice experience. And this can be with a little bit thickened liquid so they don't spill, especially to start with.
Cup.
Okay,
Now it's time for the cup.
time for a cup.
That's a boy. Tip it just a little bit. And then back away. Nice drink. Tip the cup. Nice drink.
Often better than a sippy cup, a spout cup, or something that they have to work harder to get it out. Now, we did the spoon first, so that by the time this mom presented the cup, the only thing that changed was how it got into his mouth. And that's another basic principle of intervention. What can the child do? What does he take texture-wise? How does he take it? And then make a change in one dimension in very small steps. So don't change taste and texture at the same time, or maybe even temperature, because you always want to know how to nail, I call it nail the barrier. What was the problem? So then you can back off, and maybe it was too much too fast, maybe it was too thin, maybe it was too thick, maybe, and you've got ways to then keep advancing in very functional ways. All right, liquid consistency changes. These are the questions that we always have to be asking. Examples with variables. Again, I'm not going to talk through all of these, but I'm presenting this as some descriptors and what we see, not for express breast milk, okay with express breast milk. And then you see here, reduces the thickness, smooth, slightly thick, and some things are okay for infants. Some things are not okay until children are 3 years or older. And many of the commercial thickener companies are now recommending 3 years and older for their products. So keep that in mind as well. You don't want something to be thickened and then it ends up with particles, or you think it's one consistency and then it gets thinner 10 minutes later when you're ready to use it. So some of the questions you also have to ask, what effect might they have on the GI tract? Necrotizing enterocolitis, very young infants, increase of life-threatening events. We know that the commercial thickened, Simply Thick has been banned by the FDA for young infants. All right, I've already said that, so let's move on. What happens to timing and coordination with prolonged use of a thickened liquid? If no practice is given to work toward thinning liquids and fluids, if the problem relates to timing and coordination, which in my experience and the literature supports as well, that's probably at least the greater majority. There are a few children who have progressive neuromuscular conditions in which weakness of pharyngeal musculature is indeed a problem, but those aren't the most common ones. So I've had children come to me, they've been on thickened liquids for 1 year or 2 years, and now somebody wants to know if they're ready for thin liquids. What practice has he had? Oh, nothing, because mom says I've been too scared because they all wanted me to keep it thickened. Well, that's why we have to use this really important problem solving. Here's a study that gives you some information about nipple choices with thickened liquid. A systematic process with small steps to reduce the amount of thickener gradually. Most children will transition to thin, and here's a reference for you. Now, reduction in aspiration has been shown in some of these studies. Mixed reports about managing gastroesophageal reflux, because sometimes a physician will put a child on thickened liquid because it's supposed to help the reflux. Well, that doesn't 100% either. Now, the IDDSI, I've got the slides just to give you the reference. I'm not going to talk through it. Most of you know, but if you don't, here's the website, and I encourage you to go. Here's the schema again. The testing is what is really important in my view at this point. because we can confirm flow or textural characteristics of a particular product. So we can be more accurate about that than just saying nectar or honey or slightly thicker, whatever. We measure so that the food and drinks are under the intended serving conditions, especially temperature, and for particular patient based on comprehensive clinical assessment. It's simple equipment. Here are examples of the syringes. There are some specific syringes that can be used, and that's an important thing for the measuring. Now, we have these liquid descriptors. And as I say, this one overlaps with the thin puree in the other parts of the framework. And here I'm only going to give you the thin liquid, because that's really where we want our children. For all infants and young children, it flows like water. The physiological rationale is a functional ability to manage liquid of all types safely. And then for the flow test directions, you can see the website. That's not the purpose of this lecture. Now, cerebral palsy and risks for thin liquids. I've looked for literature about that, and this is the only study, even now, because I do literature reviews pretty frequently, from 2005, a Cochrane review. Weir and Chang simply found no studies to support or refute water for children with cerebral palsy. It is true that water is probably the safest liquid because the lungs are fundamentally water soluble, not to be drowned in water. But if an infant, a child, an adult aspirates occasionally, minimally on the thinnest liquid, and we can think about it as water or breast milk, that infant or child may be able to stay healthy. But if they have chronic lung disease, then we have to take these other factors into consideration. So how can practice and experience be provided? I've already given you a couple of examples, but if we think overall about principles of management, you have to think whole child. We have to realize that total oral feeding cannot always be the goal for every child. Tubes are tools, they can go in, they can come out, and they may be absolutely critical for supporting nutrition and hydration and the respiratory status. Reflux has to be managed optimally, and anything else about the GI tract. And clearly changes in management are going to be needed as the infant develops and or there are changes in the medical condition, whether it's gains or regression. So we can have direct and indirect approaches for oral. I call in a generic way sensorimotor. I know most of you have been familiar with oral motor intervention. Remember, all the cranial nerves that innervate for swallowing, oral function and for swallowing, have both sensory and motor components, except cranial nerve 12 that is motor to the intrinsic muscles of the tongue. So in my simple head, I would find it difficult to believe that somebody is strictly sensory or strictly motor, even though somebody may be primarily one or the other. But I want us always to be thinking of that interrelationship of sensory motor, and that's why in a generic sense, I put it as one word. You can do it however ways it makes sense to you. But those approaches are really for anatomic structure problems, or for timing and coordination about bolus formation and oral, because those are the aspects that are under voluntary neural control. You can't do direct work with pharyngeal or upper esophageal function. Once a pharyngeal swallow is initiated, now the neural control is involuntary. So we have to keep that all in mind. And always considering abnormal sensory responses that may be far broader than just around the mouth. We have to think about overall gross and fine motor skill, cognitive language communication. Remember, with prematurity, that child deserves the corrected age for the first 24 months of life. So if somebody was born at 24 weeks, she can't be expected to eat her birthday cake at her first birthday, because corrected age, she's what, only about 8 or 9 months. So always Keep that in mind and help parents to understand that too. Everybody involved with the child has to understand and respect the child. And I'll talk more about some of those interactions when we do the next one, focusing on broader aspects here than just the liquids. Dietary nutrition, position posture. That's why it's so good to have a team, even if a team's not there for every session, but a dietitian, an OT, a PT, a speech pathologist, a psychologist, the physician, social worker to help the families. Thermal sensitization may be useful for some, but we have to be very cautious with infants and very young children. We monitor for changes in all of these areas. Just to remind you, this is eosinophilic esophagitis. In our ongoing assessments, we're always watching about posture and position. There are times when you can help a child to get in a good posture, in a good position, with appropriate head support, trunk control, and you don't have to do all that much around the mouth. The caregiver-child interactions are critical, the oral sensorimotor feeding status, and then of course, respiration. We may look at that little guy next time. We need more information, normative infant swallowing data, biomechanical measures, pre and post procedures. How do we really delineate changes? We need more outcomes data for specific etiologies. Clinically, I can say this child is doing better, seem to really respond to our intervention, but that doesn't really give us evidence-based treatment protocols. We need those. I have two favorite four-letter words in English, and they are what else. I say in English because we have a lot of naughty words in English, but we have a lot of nice four-letter words too, care, love, etc. But I'm always asking, what else? What else do I need to think about? What else might be underlying this? What else could I try? And we build on what we know in all of these areas. So we need to determine functional measurable outcomes, make sure that the caregivers are integral members of the team. It doesn't matter one bit what that child does with me or that baby does with me. It's what happens with the caregivers. And I basically sit knee to knee, and caregivers, a lot of coaching, and I'm sure that's a lot of what you all do too. It's important to respect cultural differences. And what are the family goals? I saw a child just the other couple of weeks ago, and the therapist had determined the goal of chewing. So it had a number of goals for chewing. And then when I saw the child to carry over, what did the mom tell me through a Spanish language interpreter? The child is still taking a bottle lying on her back. She wants this child to drink sitting up and drinking from a cup. Well, we better work on that then. And she's making amazing gains. Never jeopardize nutrition, hydration. Remember, more is not necessarily better. More intensive therapy, more frequent therapy. We've got to find what is optimal. So in summary, a stable airway is absolutely critical for safe oral feeding. We must never jeopardize nutrition and hydration. Caution urged with thickening considerations. Try to make other adjustments before we go to thickening, and then let's have plans for thinning if indeed the thickening is needed for whatever is determined to be most important. Gradual changes are usually the best, and we all have to know a lot about the whole picture, not just feeding and swallowing. It's a balance, challenges and opportunities in a whole lot of ways, and keep challenging ourselves as well. Hippocrates said this: if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to health. Part of Children's Hospital, the beautiful museum in the city of Milwaukee. Challenges and rewards for us. I rode a camel in the desert a couple years ago. I trekked in Patagonia with a couple of young men who helped me get up and down those paths, and without the walking sticks, I never would have made it. But we can always keep challenging ourselves. What else can we do? So I thank you very much for being a part of this. I look forward to communicating with you in whatever way possible. And now I'm finished.
Okay. Thank you so much, Joan, for an amazing journey through so much stuff in a short space of time. Um, we do have a number of questions. I'm going to try and sort of move around. There's a number of them around thickening, so I'm going to get to those ones. I know people have been typing them in the Q&A. We'll probably try and hit the ones that are fairly relevant, I think, to the session as much as we can. Sometimes some of the ones related to IDDSI, and that can be found in our website or other types of things.
Yeah.
So we'll just kind of go from there. There's one here that asks about a child with CP who has been on thickened liquids for some years. What age can introduction to thin liquids begin, and what age would this be too late?
I don't think it relates to age at all, because infants can do thin liquids. So it really relates to where is he functioning and how is he managing the thickened liquids. And if your best estimate is that he's needed the thickened liquids to give him a little more time to make the swallows happen safely, then whatever his age is and however you're giving the liquids, you make it slightly less thickener to that same volume of the thin liquid, and you see closely how he does. Can he pick up his
Joan, you've frozen a little bit on us
pace
there.
just
There
a
you
little
go.
bit? And maybe, yeah. So I hope I've answered that sufficiently.
Yeah, you froze for a minute there, Joan. So yeah, just in the last part a little bit. I think we missed that. Peter, I don't know whether any of that would have been captured. Do
you want me to repeat something here?
Just maybe the last little bit.
Okay. I think you can follow at whatever age and whatever means the child is taking, whatever the thickness of liquid is, to do this minimal thinning. So slightly less thickener to the liquid. And I think I gave you enough in the slides. If you go back and look at that, there's a couple of examples. And then you might first give just a little bit of the slightly thinner on a spoon, rather than from the nipple or the cup or whatever. Another thing that you might do would be to, if you think he has the potential for thin liquid and will accept a couple drops of water on a spoon, the water is thinner than his own saliva. And if you're giving him just a couple drops, it shouldn't get him in any greater trouble about risk for aspiration. So you would be kind of working from both ends, very small, very thin, and then take what's been thicker and gradually thin it down. And then you probably meet in the middle.
Okay, great. Thanks, Joan. And that actually, I think, covered off. There was somebody else who'd asked about thickener reduction, but I think you've addressed that one. There were a couple of questions about using AR milk formula anti-reflux for oral stimulation, if safe under swallow study, especially if they aspirated on thin liquids, and safe for nectar, I guess. It said to avoid development of oral aversion. There was also a question about using AR formulas in the NICU population.
I'm not going to try to answer whether an AR formula is appropriate in preterm infants, because that's really more of a digestive and nutrition. So I would defer to the dietitians and the neonatologists to answer that particular question. And I'm not in our NICU on an ongoing basis, just for patient care right now. So I don't want to go there. I think that they try to avoid that actually for preterm infants for digestive purposes. And the oral stimulation, when you think about oral stimulation and getting taste, what you're really doing is you're looking closely and figuring out what does that child accept at this point, whether it's a tiny baby or a little bit older child. So maybe you tolerate a touch of a spoon to his lip or the non-nutritive. All right, then how can you change that in one little step? Maybe it is with a drop of water on it. So he barely gets something into his mouth. That takes a lot of challenge. It sounds simple, but it's one of the most important things you can do. And it's not just a matter of getting a technique. It's a matter of really understanding neurophysiology, neurodevelopment. What is he doing? What can he do? And how does that help us approach to what we really want him to do, which is eating?
Thanks, Joan. There was questions around, somebody wanted to know about help with speech or other therapists getting started in this area, I guess, of looking. I'm not sure where that person meant, pediatrics or what, but also probably along with this would be books, other resources that might be recommended as a starting point or just a good resource.
It could differ in terms of where you want to start. I'm going to speak right now from a speech pathology perspective. And then if you're OTs or PTs or dietitians or nurses, you have to think about where it is in your profession. I don't think we get enough in our graduate programs that give us early development. We don't get anything in prenatal, early development. And it's difficult to just get it from a book, and it's difficult to start in a job in the NICU. You may be able to do it as a clinical fellow year. You need to get mentoring. Those of you who may start in an early childhood program or a birth program, because you are the ones who see many of these high-risk infants. They don't stay in the hospital all that long. They get home, and then they get followed by PT, OT, speech, teachers, etc., nursing visits. So you need a good mentor. And some of the resources, I think our third edition gives you a very comprehensive, Arvedson, Brodsky, and Left and Right, which is the third edition published just last year through Plural, is very comprehensive. There are a couple of others in pediatric dysphagia. One of the books that I find very helpful thinking about NICU is a book by Zaichkin, Zaichkin, I think. And it's aimed for parents, but it has enormous amounts of help for those of us who are clinicians. So if you can find books that are aimed for parents, they're usually less expensive and they are often very helpful. I have just picked up a book, paperback book, that was recommended to me, and it's done by a nurse in Australia, I think published in 2018. Your Baby's Bottle Feeding Aversion, Reasons and Solutions. Again, aimed for parents, but extraordinarily helpful for us and written by professionals as well. Now, some of you have specific type of job you might want to go into. I can't help you with everything, but I am willing, we talked about this before we started here, taking some email questions and for possible resources, but not to do major problem solving about a given kind of child, because that really takes too long. But I'm happy to communicate with you in any way that makes sense. We just can't cover it all here.
Just was a question about the benefits of the kind of the level 1 slightly thick in liquids for infants. Do you feel that that has changed practice, or where do you think that fits in, Joan?
We try very hard to keep our infants on level 0, on thin liquids. And we will alter position, we will alter nipple flow, although you can't find a perfect nipple, timing, making sure that all of those factors are as solid as possible. And as soon as you go to thicken something, now you're introducing some other material into the liquid that you're starting with. Breast milk may thicken up with certain thickeners, but it does not thicken up well with all thickeners. And if you get particles, or you think you've got a consistency and then it settles out, even if you've used your syringe. So it just gets much riskier, and you're using a lot more variables. It's also important, those of you who do video swallow studies, if there's one aspiration event on a thin liquid, that doesn't mean automatically go to a thicker liquid as the first attempt at intervention. You may change the positioning, you may change something else. And those things are important as well. So I'm going to urge people to do all of your broad problem solving, and you may thicken for some. I'm not anti-thickening, but I am not a proponent of just kind of generic thickening as well. Let's just thicken the liquid and see how the child does. And I think you are problem solvers, or you wouldn't have bothered to get in on this lecture and take this time to do it, no matter what time zone you are in. So what I mentioned in the need for research is that we need a lot more evidence-based outcomes in order for us to be confident about making some of these changes that seem to make sense clinically, but don't necessarily give us the information that we need about intervention and then in turn the outcomes. So I just kind of have to hedge, and I think it is one of the most difficult things for us to do. And you can't just make a decision and then think that's going to be that way for 2 or 3 months with a really young infant and child. That child is going to change as well. So be open for the challenges. That's really about all I can tell you.
That's why I think we work in pediatrics, right? Love challenges.
Yes. And I will tell you, people who work in adults, my colleagues tell me, I don't know how you can work with those babies and children. How do you make decisions with those? They can't even tell you.
Yeah. It's a tricky world. We are kind of at the end of our session here, and I know there is still questions in the session. What we'd like to do is say that Dr. Arvedson will have a chance to look through some of them that are relevant to the topic. We'll certainly try and maybe put them in on the next session in April 22nd. I will ask her just before we end to go, maybe just put her email back up. A couple of people asked for that. I would like to mention again a thank you to our sponsors. I will say that the sponsors do not have any influence on IDDSI, IDDSI, and the work that we do, or on any of the webinars or presentations that we provide. So they're simply as a support to allow the work to be done. So that's a huge thank you to them for that. And an enormous thank you to Dr. Arvedson for an incredible, thought-provoking and informative presentation, and look forward to maybe seeing some people back again for another review of this presentation in April. So thank you. And we did put the meetings at IDDSI.org up. Email in if you need to contact in to get your certificate. So thank you very much. Signing off, and until next time.
Thank you.